Okay. So, are you guys able to see this?
Yep, I can see your screen.
Is it better?
Yeah, right now we see that you're on YouTube.
I'm on YouTube. Oh, you see that screen?
Yeah.
I have to share maybe a different kind of screen. Let me just unshare. And share the screen. Which screen do you see now?
Now I see the images.
Excellent. Okay. So, Neil, describe what you see.
Here we go. So I see, so the one in the middle, this is a sagittal view of the lumbar spine. This is a CT scan.
It's a CT scan, correct. In tissue window or in bone window?
Bone window.
Bone window, yeah. What does it make a bone window?
Because the bone has a higher density than the tissue.
Yeah, and in a tissue window, the whole bone is just like a walled white blob. As a matter of fact, look at the middle one, the windowing is not exact. So that's why you see on the left side, you see the bone is crisp. You see even the trabeculation inside of the bone. You see the hyperostosis at the edge of the bone. Whereas here in the middle, you don't really see much of that. So you know that you can window a CT or MRI, right? Now, when you window it, you don't have only bone window or tissue window. You can window anything between as well.
And
So
with the windows, is it a similar technique like with T1, T2 weighted MRIs, or is it totally different?
No, you'd never make it. No, T1 and T2 MRI are inherently different kind of pictures, are produced in a different way. The way the images are produced are completely different. Whereas in CT, tissue versus like in the CT, you get a voxel, a volume value. That value can be minus 1,000 to plus 1,000, or can be 0 to 2,000. Whereas in the T1 versus T2 or different modality in the MRI, those values are different generated, is not comparable. That the one value in T1 doesn't mean is the certain value to T2. Okay, so and windowing, I think as a matter of fact, that would be, again, it all comes back that if you understand the physics of it, it makes much more sense to you. But having said that, so this is a CT of the lumbar spine in bone window. Let's say this is what it is. So keep describing what you see.
So for the sagittal view, the CT of the bone window, I see the lumbar spine. I see the vertebral columns over here on the left, and on the right side, I see the spinous processes. So in the middle would be the spinal cord, but I don't have a good visualization of it.
Because it's a bone window.
Because it's a bone window.
You don't see the tissue differentiation is very poor.
I'm not sure if I'm accurate, but maybe L3, do I see osteophytic changes, or?
Are you talking about now, so you see pre-op, obviously. On the left, you see pre-op chronal. On the right, you see post-op chronal. Middle, you see post-op sagittal, because you see the hardware here.
Yeah.
In the middle and the right, you see the hardware. So which one of these three you want to describe first?
I will describe. Okay, I'll describe the pre-op window.
I think that's a very good idea. Go ahead.
Start with that one. So we are in the tissue view of the CT, and this is a coronal view of the lumbar spine.
In the bone window.
This is in the bone window.
Okay, good.
And for some reason, I'm seeing, I don't know if I'm right or wrong, but scoliosis, or I see like an angulation of the spine.
Absolutely right. In the coronal view, the
Mhm.
spine should go straight up and down. It doesn't. So that's the definition of scoliosis.
Mhm.
If you look carefully here, I even measured between L3 and S1. I measured that scoliosis.
The angle, I see. Is that the Cobb angle?
That's a Cobb angle. Correct. Correct. Now, anybody else? We should go after I
Yeah.
go with Neil over that.
I think I saw John's hand raised. John, did you
Yeah,
want to jump
good.
in?
Well, why don't you describe the pre-op window and then we go for John for post-op, okay?
Okay.
So you are absolutely right. We see a so-called scoliosis with a
Mhm.
Cobb angle of 14.2 degree or 14 degree to what side?
So would it be towards the right side? Are you going with the concave or is?
Well, first of all, in this picture, I'm here.
Mhm.
Which side is here? Which side is this?
So this is the patient's view. So this would be the right side.
Where am I? Do you see the hand?
Right now, that's the patient's left.
No, so, okay. Do you see the hand?
Yeah.
What side of the patient is that?
So is this not the patient's? Well, if this is a CT scan, isn't this the patient's left side?
That's the patient's left side.
Yeah.
Now, in all anatomical images, when you look at the coronal, like you're looking at the patient's face, like you and I are talking. My right is your left and vice versa, correct?
Yes.
That is how you look at the patient when you look at the coronal. When you look at the axial, you're looking feet up. Like patient is laying in the bed, you're at the foot side of the bed and you're looking up. If you memorize that, you will never make a mistake, okay?
Right.
So you're at the patient is laying on a bed, you're at the foot side, you come to the room, you're talking to the patient at the foot side of the room. What does that mean? Your axial images, you're looking up, and coronal pictures are flipped because you are face to face to the patient.
Mm-hmm.
Okay? Okay. So, and we call for, so now you know which side is which side, but if I would, radiologists call it the levo for left scoliosis or dextro for right scoliosis. You guys are familiar with that? Levo scoliosis, dextro scoliosis, Dexter?
I'm assuming that dextro means it's turning right.
Yeah. So now that's very interesting. Most of our nomenclature is Latin, right?
Right.
Have you guys heard the word dexterity?
Yeah, of course.
Which hand is more dexter than?
Well, I guess for the general population, I'm assuming the right hand.
Because right is dextro, dexter in Latin, and left is levo. Dexter, levo. Okay? When you have the chirality for the molecule, you see L or D. Right turning or left turning, dexter or levo. Okay, same here. We use the Latin terminology. So it's a dexter to the right, levo to the left. So this is turning to the left or right? The convexity.
Is it level?
The level scoliosis. So it is a level scoliosis L3 to S1, 14 degree Cobb angle. Okay?
Okay.
So tell me, what else do you see there?
I do see, I don't know if I'm right or wrong, but are those bone spurs or on the?
Oh yeah, there are definitely bone spurs.
Yeah, osteophytes.
There's a significant osteophytic changes, yes. But
even on L5 or the
yeah,
significant osteophytic changes there.
Absolutely, yeah.
And I see that. Well, I'm not so sure if I could see herniation or anything of the disc since we're in the bone window.
You wouldn't, but I do see it here. Here, look at that. You see that if you look carefully, that in the 3, 4, I'm sorry, 2, 3, 4, 5, 2, 3, you see that here? Like something coming out. There is a disc herniation, and you see the disc here herniating here, but that is not really consequential in this situation because lateral disc herniation, so what? Really nothing there to cause any significant amount of, but that means it's a bad disc. So what are these long structure coming down like here?
Is that these, this is a muscle. I'm assuming it's psoas. Is it the psoas muscle?
Iliopsoas, you know.
Iliopsoas?
If you look carefully, you see that the small little, you know, divide in it.
Mhm.
Okay. And then obviously you see this structure here. What is that?
That's the sacroiliac joint.
Perfect. What is, you see on the bottom, you see like almost like a upside down V, and inside of the V, you see a whitish structure surrounded by dark structure. What is that?
It's white structure surrounded by dark structure. I'm not.
Here, down where the hand is now, right there. You see the hand?
Yes.
The hand is pointing to a white structure in that upside down V. Do you see that there?
I do see it, but I'm not sure what it is.
It is a hole in the sacrum. What holes are in the sacrum?
Oh, the hole in the sacrum. It's not called the ala, is it?
No, ala is here. Ala is the wing.
Ala means, okay, that's the wing.
So
is it just the foramen, a sacral foramen?
Yes, that's the only foramen I know in the sacrum. It's a foramen. But which foramen is it?
So, with like right or left?
Well, you know, there are two of them, obviously, right? Flipped. This is the left, this is the right. But how many holes are in sacrum? Let's ask you this question.
One. Four. I believe there's 4 on each side, so there's 8.
Sacrum is made of 5 bone that they coalesce together. Okay, and almost everybody has a S1 and S2, but some people maybe have S3 and S4, but barely anybody has S5. Okay, it's very variable, but so we have a S1 foramen where the S1 nerve root going. So I give you the answer. That white structure in that upside down V is the S1 nerve root.
Okay, S1 nerve root. So then from every foramen would have S1, 2, 3, and 4.
Well, S1 and S2, almost everybody has S1 and S2. But yeah, probably half of the people have S3, and then becomes less and less common after that because they don't really have any function anymore. So what else do you see in this picture?
Well,
what is that big structure up here?
Is that the kidney?
Yes, there are 2 kidneys. You see both of them are part of the right and most of the left. Okay. And then I'm going to ask about the ala. It is here. What is that structure right here?
The ala, so is that the iliac crest?
That's why it's called sacroiliac joint. Okay. One last thing, this darker structure surrounding the kidney, what is that?
The dark structure surrounding, is that just fat or is that just tissue or?
Just fat, correct. What kind of fat is it? I mean, that kidney.
Peritoneum?
Retroperitoneal.
Retroperitoneal.
Kidney is in retroperitoneal space, correct?
Right.
But you see a little bit of a bowel here too. So somewhere it's here peritoneum, but definitely kidney and iliopsoas muscle are not in peritoneum. They are retroperitoneal structures, correct?
Yes.
Okay, so John, are you going to want us to discuss the middle picture with us?
Yeah, sure.
Good. Okay, so describe what you see.
Well, you know, it's a sagittal view. Looks like there's some artifact in the middle there, probably post.
Very good, very good. Now, I'm going up and down here. Tell me where the artifact is, because I want to be sure that you know what's artifact and what's not. So
like maybe L2, 3.
So
3 for sure.
Is that what you're referring to, artifact?
Yeah.
Well, that's not an artifact. That's real. Artifact means it's not real.
Okay.
Maybe that is real. Do you know what that is? Where my hand,
like a screw or something?
That's a screw. The screw is real. So it's not an artifact. But look at this here. Do you see here? Do you see the dark here?
Yeah.
That is an artifact.
Okay.
And why is it an artifact? Can you
Is it
tell
like
me,
there's
John,
like the
why it's an
muscle's
artifact?
supposed to kind of continue longitudinally and it seems disrupted?
Well, it seems that it's going that just across like that. Do you see that there, almost there?
Yeah.
Now, and here as well, you see that here, you almost see that. You're here, you almost see that. But look at where you see the screw is not as strong. Here, you don't see the screw. By the way, we call that metal artifact.
Okay.
But do you have? Can you tell me for what reason where you don't see the metal, the artifact is stronger than when you see the metal?
Not sure.
Any takers on that?
Is it because the vertebral body there is denser than the other one?
No, no. We did a really nice thing about how CT is made. CT, the actual picture, is actually axial. Imagine this is the cross section of your body. This is the bone inside of your body. In CT, are you guys able to see that? In CT, there is an X-ray machine that literally goes around, like, this is the one part of that camera, this is the X-ray source, and the X-ray shoots from here, it shoots up there and there, and then it rotates around our body, and volumetrically it calculates the volume. In each volume, it calculates the density of each volume. Okay, so it goes around. This on the outside, it turns around the patient, and in certain point, it shoots pictures. It shoots that goes like a 30 or 60 degree, shoot another picture, and then another picture, then another picture. If there is a dense material anywhere here, like imagine you have a very, very dense something here, behind that dense material, you will get streak artifact. Anywhere behind that, you will get the streak artifact. Now, knowing that, come back here. These pictures are not original pictures. The original pictures are cut this way. The computer gets those axial images, reconstructs sagittal and coronal views. That's why we call them recons. In CT, we call the sagittal and coronal recons. Now, those pictures are produced in this axial plane, and depending on what angle the CT shoots those X-ray in the axial plane, you will see those streak artifacts going in the sagittal and coronal views. You see them going horizontally, and not necessarily where you don't see necessarily metal and the artifact at the same place, because it didn't necessarily shot that picture from back to front at an angle. It cuts it at an angle. That's why you get this artifacts. But there are artifacts for multiple reasons. Number one is that they are in the axial plane. And number two, on one side, it is whiter, and on the other side, it is darker. Look at all of them. You see it on one side, and that is just a mathematical thing that how it's calculated. Again, we made a video, a podcast about how this physics of this is, and then it makes sense if you understand that. But either way, we call that metallic artifacts, so they are not real. And that is what you need to look for to see if something is real or not, because John, here, do you see the dark here?
Yeah.
That is not an artifact. You see how distinct the borders are? And it's not like a streak artifact. It doesn't strike to one side. And it's not that one side is dark, one side is white. That's how you know they're not an artifact.
And you wouldn't expect any artifact in the first one because there's no metal that would be doing that, right?
It doesn't have to be metal. Anything very, very dense can give you an artifact. But obviously, most of the time, the densest thing in your body is the metal that the surgeon put in. Okay.
Sure.
Okay. So, go ahead. What else do you see here? So you see the so-called the metal streak artifact in each level, which is because of the screws. Screws are dense metals. And the reason you don't see the metal and the artifact at the same level is because the angle where the pictures are produced is not anterior-posterior. It is like a maybe 30 degree or 60 degree to it. And that is why you don't see them. But either way, you just dismiss them. You know they're artifact and you're dismissing them. So I'm going to point to some structure. You tell me what they are. Where is the hand now?
Is this just a spinous process?
Yes, there are spinal process, all of them. Is this spinal process broken?
I think it's just a cut.
What do you mean by that?
Like like just the layer that the CT is taking right now might not fully encapsulate the center of the spinal process.
Well, if you look at the the patient has a scoliosis, right? Obviously, after the surgery is not as bad, but knowing patient have a scoliosis, meaning that it's sometimes hard to get a cut that you see practical midline of all bones. So because it's a little bit of a side bending or a little bit of a anatomical kind of abnormality here, this is not a, how do I know this is not a broken bone? Because God knows, maybe I did the surgery, maybe I did break the spinal process. The way you know that, look at the, if you want to see a true fracture, look at the edge of the bone. Edge of the bone in a fracture are, they are not hyper intense, they are not hyper dense, meaning they are not thick, they are not super wide. Like, do you know what I mean by that, John?
Yeah, you might, if it was an acute fracture, you might see some inflammation around the area too. And
No, the bone itself. Let me try to find a broken bone for you on a CT. See, let me just here. And that applies to any kind of CT, anywhere in our body, that you can very easily say if it's a, it's a bad cut, if it's a broken bone or something else. Let me, now that I'm looking for that, it's hard to find on Google. Yeah, no, I'm sure I will find it for you, but just if the edges are, okay, here, I think I found something here. Look at that here. See, the edges of the bone, they are not cortical bone. Do you see that there, here?
yeah.
Whereas in our picture here, the edge of the bone is cortical bone. That is a good indication that it's not a fracture. Or it could be an old fracture, because if it's an old fracture, the edges could calcify. At least we know it's not a fresh fracture. In this case, I'm pretty sure it's not a fracture. It's just because the patient is still bending and twisting a little. It is, you didn't get it in the right cut. So, what is that structure here where the hand is shown?
That's just the start of the sacrum, right? S1.
And now, where am I now?
Maybe like S2. I'm not sure. Like
that's a remnant of S1, S2 disc. You see that there?
yeah.
That's a remnant of S1, S2 disc. Because that part of that is calcified, and as it should be, is normal. In the pre-op picture, in this coronal picture, you see those two dots there. You see those two dots there? This is not a real disc, and it partially calcifies. That's why you see it that way. What is that structure coming down here, John? What is that?
Looks like a muscle.
In the front, exactly in front of the vertebral body, What muscle would that be?
Is that
Not a
like
muscle. Let me tell you, it's not a muscle. What is
is that
exactly
like aorta?
correct? Correct. And look at that. Is that an aortic obstruction? Aorta seems to be stopping at L4. What's going on there?
It's where L4 is where the aorta bifurcates.
Two, what vessels?
The common iliac,
And then?
and then external and internal.
Correct,
iliac.
correct. So it's a typical, unfortunately, I had one that if you, especially for L4-5, when you do surgery there, and if your instrument goes forward, they may injure common iliac artery. Okay, especially in that angle. So let's. What else? I think that we are done here.
Yeah. I think Lucas or possibly David would like to take the third image.
Okay, so Lucas, it's you now. Go. What is this?
Oh boy.
Interesting case.
So we're looking at the sacrum here. This is again a coronal, seems to be an X-ray.
Well, yes. First, start with what is it? It's a X-ray.
Mm-hmm.
The lumbar spine, correct?
Well, yeah, the lumbosacral.
Well, pelvis. It's not really pelvis. It's a X-ray of the sacroiliac sacrum. It's an X-ray of the sacrum. So
Right.
Go ahead.
And again, yeah, so it's coronal view, so our left side.
Well, if in the X-ray we don't use the word coronal, what do we use? It's lateral, AP, inlet, outlet. We have different name for the. If you take a CT of the sacrum, just looking at that, it looked like a regular AP to me.
AP, okay.
And you see that there, they put an R here.
Yeah, to indicate that's the patient's right side.
Correct. So describe what you see here.
Well, I mean, the first thing I can see is if I jump to the sacroiliac joint, which I assume is what we're looking at, I can see that there's some sort of maybe trabeculation or autofusion there.
You couldn't really say if it's autofused or not because X-ray is a accumulative kind of picture. Mm-hmm. It wouldn't really let you see if bone is growing from one side to another or not. But it is, let's agree, it is not a normal looking sacroiliac joint. Mm-hmm. The arthritic sacroiliac joint.
Right, yeah.
Okay.
Osteoarthritic maybe.
Yeah, right? Sounds good. What else? What else do you see? Something is eating into the sacrum. Do you see down here?
Yeah, so would that be normally the beginning of the coccyx there?
No, coccyx would be much lower.
Okay.
But do you see this?
Is that
almost like cancer? Yes, that's stool. Okay, that is not cancer. That eating into sacrum. That is stool. Why does stool look like that?
Wow.
Why does in rectum? Is a stool in rectum? Why does?
Is it a density issue? Is it because it's so dense at that point, or?
Well, is it dense?
Well, it's had water. It's had water added once you get to the rectum. So.
Well, it is dense material, but it's decomposing, creating gas.
Okay.
Right?
Oh, so it's like the bacteria.
Well, no, you don't see the bacteria, but you see these small areas where air accumulates, right? So imagine it's a dense material, and then some pocket of air in it, because of the decomposition, bacteria produce methane, air, and that air is within the stool everywhere. Sometimes it comes out. We call it what do we call it when it comes out? We call it fart or flatulence or whatever. But this whole stool, this is the characteristic how a stool look like in the X-ray. It look like a denser and less dense stuff because it's material and then gas chambers within it. Does that make sense?
Yeah, absolutely. Thank you.
Okay, so if you see something like that, especially in the abdomen, no, only in abdomen. If you see anything like that anywhere else, it's a very concern for cancer. Okay, but in the abdomen, well, why does cancer can look like stool? That is a good question now.
Is it?
Lucas? Who's doing it now, David or Lucas?
You can go, Lucas. I'm sorry.
Oh, who's talking now?
That was David. This is Lucas now.
Okay, Lucas, why does cancer can look like stool in your body with the X-ray?
That would be if it's like an osteoclastic process eating at the bone.
Anywhere. That doesn't even need to be bone. Cancer anywhere in our body, if you get an X-ray, if it's very, very advanced, it can look like stool, can have this appearance. So what is the characteristic of cancer? Tissue grows without control, without boundaries.
Right.
It outgrows the vascular supply. And what happens? Then you have lots of dead areas within the cancer.
I see.
So lots of areas with different density. Okay?
Necrosis.
Necrosis. And guess what? The stool there is as well, it has the same characteristic of the necrosis. The necrotic material falls apart, created air, and then you have this vast difference in density and chambers with denser material, less dense material. So, and that's the same characteristic of the advanced cancer, that it literally outgrows the vascular supply, and then you have lots of internal necrosis within living cancer tissue. But here it is not cancer. Okay. So, let's ask few questions. A while back, we talked about ALA. Now, I'm going to go up and down. Lucas, tell me, should I go up or down to go toward ALA?
Up.
Up. Tell me stop.
Stop.
Okay, now where do I go now?
You can go left or right.
Here, you're absolutely right. These are the ALAs, like the wing. ALA is wing. Okay, is the wing? You see, it almost does look like a wing, doesn't it?
Yeah.
Okay. Now, advanced question, Lucas. What is this?
Would that be the foramina of S23 or S12?
Well, I would go with the S1. It's hard to see in a regular picture, but I would go probably with the S1. But you see, with all the gas and so on, it's really hard to see. And if you really want to see the foramen, you have to get the so-called outlet view. This AP view is not the best picture to define which foramen it is and if it's a foramen or not even. But a so-called outlet view is a true AP view of the sacrum. Then you see the foramen much better.
Yeah, you have to, because right here, is there like an angle of the sacrum going?
Correct. You got it. Now, another advanced question. Where's the hand right now? What is that?
That would be my anatomical terms are lacking, so I apologize.
No. What, to describe it in English, what is that?
Your femur, the head of the femur, maybe?
Head of the femur, yeah.
That
Okay.
would be, yeah.
So, and this structure right there, what is that?
That's a really good question. That would be maybe the spinous process then, right?
Correct. That's a spinal process. And this?
Those are the pedicles on the left and right of the vertebral body?
No, where the hand is.
Oh, is that not a pedicle? That's a transverse process?
That's the transverse process.
Okay. Is the pedicle between the body and the transverse?
Here's the pedicle.
Okay, thank you so much.
Right here. You see that there on each side? And up here, they can be different size depending on the angle. They can be visible or not visible, and so on and so forth. Okay, I think we sort of did that. Who's next?
I think, David, do you want to go next?
Sounds good. Yeah.
Go ahead. What do you see? What is this picture? What kind of picture is it? Start with that, always.
Okay. I'm real new, but I thought that
It's
was
the
going
best.
to be
That's the best.
good. That's good to
You
hear.
can learn most. Okay, go.
I mean, obviously, we're looking at our side view of the spine.
We don't call
And-
it side view. We have an
Yeah, thank you.
anatomical.
So is this an X-ray?
No, it is not an X-ray.
Okay, so is this a CT?
Not a CT, but
So
you
it's
can
an
go-
MRI?
It is an MRI, right?
Cool. Process of elimination.
So why is it an MRI? Why, first of all, why is it
Okay.
not an X-ray?
I would think for this, it's because we're actually trying to look at the spinal cord itself, and we're trying to look at our. Are we trying to look at like the?
Eventually, it comes natural to you, but it is not an X-ray because X-ray is an accumulative picture of the entire body.
Okay.
At that, like, this is an X-ray.
Yeah.
Right? You don't see any detailed structure here, whereas this is very detailed. So this can be only CT or MRI.
So once we see detail, we know we're limited to those two. Is that a?
Yeah, if you see so much detail. Now, in CT, fat is less dense, fat is dark. In MRI, fat is white. Both in T1 and in T2, fat is white. So if fat is white, you are MRI, not CT. But as well, there's some, I mean, it's really hard to mistake them after you have seen 10 of them. Now, the second thing you want to know, so this is the MRI, this is how you describe a picture. First, the modality, what is it? This is a CT, MRI, X-ray. So we said this is an MRI. But then what region of the body? What region of the body are we looking at?
We're looking at the lower spine.
We call it lumbar spine.
So lumbar spine, great.
This is the MRI of the lumbar spine. Now, MRI is a little tricky. It comes in different kind of sequences. Sequences are the way the pictures are produced. We call them T1, T2, SPGR, STIR, and so on and so forth. But for all practical purpose, remember two of them, T1 and T2. The T1s are so-called anatomical pictures. The T2 are so-called pathological pictures. Because everywhere where you have lots of fluid, when you have a damage, you have lots of fluid. The fluid shows up white in T2. For that reason, T2 are called the pathological images. Now, where do you know lots of fluid in our body? In the cerebrospinal fluid, right?
Yeah.
So is the cerebrospinal fluid white or dark here?
And we're saying that this is going to be anatomical, not pathological?
No, well, I'm not saying the image is just called that way. But
okay. Yeah, I would say this is darker.
CSF. This is CSF, right? Here.
Oh, then that's lighter.
Yeah, the CSF is white, so this is a T2. But the T2s are as well called so-called pathological images because pathology is more visible on T2 than on T1. So if I was going to describe that, I would call it a lumbar MRI T2 sequence, sagittal T2 sequence, okay? So now we identified what it is. Let's go back and forth. I just told you fat is white. And it makes sense, right? Under the skin, we all have some fat. Not really much in this one, but as well, the inside of the discs are white. Why is that? Is it pathologic or normal?
I would say it's just the cushioning, like the nucleus pulposus.
Yes. The fluid for a disc is like air for a tire, and the disc is like a tire, okay? So that is normal. As a matter of fact, this one is not normal, where it is dark. Do you see that there?
Yes, so we have a lack of that cushioning.
Yes. Now, what level is that?
We're hitting around, I'd say we're getting to sacral. So I'd say at the very bottom, we're probably seeing S2 to S1 with that curve. So I'd say, is that right?
Around the hand is, what level is that?
I'd say L5 to S1 is about that area.
You're actually right, but I'm a little afraid that you're right for wrong reason.
Okay.
So let's dissect that a little. How do you know this is not L5 and this is not S1? How do you know that?
Man, I was going off the curvature and the size. So I think you got something for me. So,
but this, you see, that is a good conversation here now.
Okay.
It's an advanced conversation, so don't feel that you're overwhelmed. This bone here, you see that there? That looks like a fully developed bone. And that disc looks like a fully developed disc, doesn't it?
Can I guess what you're getting at? Can I see if I'm tracking? Okay, so earlier you're talking about how things were coming together, obviously, when we're getting down to the sacral. So is it because of the fusion that things are going to be smaller with the pulposus?
This
Okay, thank
patient
you.
doesn't have a fusion. This patient is pre-op. Doesn't
Okay,
have a
okay.
fusion. But look at that here. This here looked like a, you see this, there's no question. This disc is not a regular disc, correct?
Yes, yes.
In about 1/5 of the people, S1, S2 disc almost look like a normal disc, but what
Okay.
it gives it away is like the size and the shape of it.
Okay.
That it's, look at this disc, is look like a mini version of this disc.
Mm-hmm.
Okay, usually L5S1 disc need to be bigger than the L1, 2, 3 disc because it's a bigger vertebra, has to have carry more weight on it. If all of a sudden you see a disc here, it's fully developed or seems to be fully developed, but is way, way smaller than 4-5 disc, you have to just, your red flag needs to go up.
Okay.
So because,
So
go ahead.
with your red flag, so are you saying that that's pathological if you see that?
No, I'm just saying,
Oh,
this patient, this is not a pathological disc, but this is not a L5S1 disc. This is a
that's just
S1S2.
identifying.
See, how many lumbar vertebrae do we have?
We have 5.
About 15% of the people have what we call transitional anomaly, meaning that that L5 is L5S1 disc is not the very bottom disc.
Okay.
Okay, that they have one extra vertebrae. As a matter of fact, I just did a surgery today on an S1, S2 patient where the radiologist read it as L5S1 because to really know which level is which level, you have to get the whole picture. You have 12 thoracic, the L1 start where you have no more ribs attached to the vertebral body, and then you count down. You see which one has the lowest rib, and then you count below that, it becomes L1, L2, L3. And this patient has 6 vertebrae like this. What, and again, don't feel overwhelmed here because even the radiologist missed it today. I just did the surgery.
Oh, wow.
The radiologist missed that. It looked exactly like that, and he called this L5S1, and he called this level L4-5. Whereas if you count the rib, that would be 5, 4, 3, 2, 1. And this one was S1, and I did a surgery on here. That was S1, S2. What gives it away is L5. There is no reason for a real L5S1 to be smaller than L4-5, L3-4. If you see that the bottom disc is smaller, your red flag needs to go up. Maybe this one is a S1, S2. And the way to figure it out, you get a CAT scan, and in the CAT scan, you see where ribs are stopping, and then you count down.
Okay. Thank you.
This was tricky. On the right side, this disc here, where the hand is it normal or not normal?
I mean, going off the size compared to the others, I would assume that it's not normal.
That's not normal. You're absolutely right. You see, you're absolutely right. Look at the shape as well. It's not lens shape. It's flattened, and then the end plates are as well changed, and that is definitely not normal. So that is how a degenerative disc disease look like. Okay. So
awesome.
Who's next? Let's start. Let's look at. Oh, that's a good one. Okay, I can't wait to drill the next person. Who's the next person?
Who wants to go next? Any takers?
Any takers? That's the best way to learn.
Really quickly, if we can go back to the previous image, if you don't mind. I had a quick question about the
previous
T10
picture. This one?
Yeah.
Okay, go. What's the question?
T10 to T11. Is that flattening of the disc space there with slight impingement?
So I'm calling this 5, 4, 3, 2, 1, T12, T11.
Okay, T11, T12. Yep.
Are you talking about this?
Yeah, is that
This is the same as this.
Yep. And then on that image,
This is thoracic, this is lumbar of the same patient.
Right. So on the right image,
Here,
yeah, we can see, is that impingement on the spinal cord there from
are you
those?
talking about this?
Yes, and the one below it too.
That here and
Yep.
here? Well,
Yeah,
look
would that
at
be
how much
considered
space is
impingement?
in the back of the spinal cord.
Mhm.
Definitely is not a normal disc, but I wouldn't call it impingement or herniation in any significant way.
Okay, so that one.
Or stenosis, because look at that. So much space still left in the back of the cord.
Okay.
Cord gets out of the way. I wouldn't call it a spinal stenosis. That is the term we use.
So it's just stenosis of the foramen, but it's not impinging.
No, you wouldn't see the foramen. To see the foramen in the actual image, original image, you can go back and forth and look at the foramen and then see here. I couldn't say from this picture alone if there's a foraminal stenosis. I can just tell there is no spinal canal stenosis.
Oh, okay. Okay. So the big central foramen, we're considering the spinal canal.
Spinal canal. We don't call it really foramen. Foramens are on the side where the nerve roots are coming out, which is not in this picture. I cannot say one way or another if it's stenotic, is the stenosis or not.
Thank you so much.
You're welcome. Next, who's next?
Lucas, do you want to go for round 2?
Oh man. Okay. Okay, so here we're going to see. Oh, is this a CT again?
Yes, it is CT.
Okay.
Because the fat under the skin is dark, not white, correct?
Correct.
Okay.
And now we are looking at the cervicothoracic region.
Cervicothoracic region? Guess again.
Guess again?
Yes, guess again. It's not cervicothoracic. It's
Really? So it's just the thoracic region?
just the thoracic region,
Okay.
yes.
Are those cervical vertebrae at the top?
Then you may be able to see the bottom of the C7 there. But
Okay, because I was looking at
this picture is not called the cervicothoracic. It's an entire thoracic vertebrae.
Okay, thank you.
Go ahead.
And then so on the left side here, the
Left side, okay.
the image A, labeled A,
Mhm.
I can see some hyperdensities in front of the vertebral bodies.
Good. What are they?
Would that be? That wouldn't be the I forgot the term for the ligament.
Anterior longitudinal ligament. I'm talking about anterior longitudinal ligament and posterior longitudinal ligament.
Okay, so it would be the anterior longitudinal ligament. Maybe.
Why don't we start with things that you absolutely recognize? It's always when you look at the films, start with things that you absolutely know what they are. Like this is skin of the back, this is the subcutaneous tissue or fat, then paraspinal muscle, and look at this structure here.
Right.
What do you think what they are?
Those are the spinous processes.
Are they?
Well, now you've got me concerned that
Yeah. So look at that here on the right side. That is the spinal process.
Okay.
Is that the spinal process right here where the hand is now? Very small spinal process, right? Spinal process is in the middle, right?
Yep.
If patient has a little bit of a side bending in the same cut, you get the spinal process in one vertebrae, but then a little more to the side, you get the joint that connect in the back of our body, two vertebrae together. What that joint called? Called facet.
Oh, the facet joints. Okay.
Yeah. Do you see how it is truly look like a joint here? That here and here there is a articulating, and then look at that. Now that is a foramen right there. Now the reason you see spinal canal and the facet and foramen in one sagittal picture is because the spine is side bending.
Yeah, so some scoliosis there.
There's a scoliosis. If you see something like that, you know automatically there's a scoliosis. You don't even have to look at the coronal view to say this patient has a scoliosis, but look at that. So spinal process here, and then lamina, and then facet, again, lamina and spinal process.
Oh, wow. Thank you so much. That helps a lot.
Yeah. And foramen here. Now let's come back to the other picture. Now that you know what to look for, what are those here? What are they?
So those are the facets.
Facets. And here, facets are becoming lamina.
Mhm.
And here, you see the foramen of this 1, 2, 3, 4 of them. You see the foramen as well. Do you see the foramen now?
Yes.
Okay. So these are the facet. This is the foramen. This is the vertebral body. This is the disc. This is the spinal canal. And then in the front, bunch of these bones are growing together.
Mhm.
And look at the middle now. That is as well interesting. And we are going to now, this is the last picture we are going to look at. But tell me, do you see that how the bone is actually growing all together?
Right.
What is the Latin? Actually, this is a Greek term, old Greek term. What do we call when the bones are growing together? Logically.
Osteophysis.
No, but there is a name that we called it. Have you heard the term ankylosis?
Oh, ankylosing spondylitis. Okay.
Spondylitis. Yeah, you actually diagnosed this patient now. Okay, ankylosis because its bone is growing together. Spondylitis meaning it's in the spine. Spine growing together where it shouldn't. Ankylosing spondylitis. There is another name for that. Old name. We don't use it anymore. In Europe, they use it still for that. If you tell that, you get it. You get it a present from IS Life. Who knows what is the other name for ankylosing spondylitis?
They used to call it bamboo spine, right?
Well, the bamboo spine is because we just describe it that.
Okay.
Because it looked like a segment of the bamboo, but there is a doctor who described it first, and in most of Europe, we don't call it in the US like that anymore, but have you guys heard the term morbus Bechterew or Bechterew? B-E-C-H? No, you never heard. You guys never heard that, huh?
No, we haven't.
The poor Dr. Bechterew. It would be so sad. You guys are not using his name anymore. But that is, we used to call it morbus Bechterew or Bechterew. B-E-C-H is a German guy who found that, and now we call it ankylosing spondylitis. And look at that. All of them are growing together. So, and here, it's trying, these are not the same patient, by the way, okay?
Oh, they're not the same patient, yeah.
They're not the same patient. Look at that. Here, this one is growing. In the middle, this one is not growing. This one, all of them are growing. This one, all of them has, no.
They all have some degree of scoliosis in the same region, in relatively the same region.
Yeah, that's nothing unusual.
That's interesting.
Or maybe the person who put this together just chose them. Let's show that, okay? Now, how do I know they are not the same patient? Seriously, how do I just look at them? Here, now that you know it's not the same patient, it's hard to believe it's the same patient, correct?
Right, because we can see
all the differences now. You see now all the differences. But you see as well these lots of disc osteophytic changes in the front here.
Yep.
This one, they don't have it because the bone is growing. Okay. Okay. Any other question?
Wow, that was it. Thank you for the insider scoop of that. If I ever get pimped on ankylosing spondylitis, what's the origin? So actually the other day I was pimped on do you know the name of the song that clowns usually play at in circuses? That one. There's a name.
The name of that song is I heard that, but tell me, what is it?
I think it's Welcome the Gladiators. I think it was composed by an Austrian artist for the military. And then it ended up being used. I didn't know the name of it, but I knew the history of it somehow.
Wow. Yeah. It's lots of things have interesting background, and sometimes when you know the background, that's the best way to remember it.
Yeah. Definitely.
Otherwise, it's just another piece of memorizing. But when you know what is behind that, it's always help you to keep it in your memory.
Right.
So,
thank you for today. You definitely drilled us harder. It's like taking it to another level. So we appreciate that.
I'm happy you guys liked it. Now, I think, we should, Neil, you know that in summer, Amanda wants to work with you, create a boot camp.
Yes. We can definitely, I know the students we would all appreciate a boot camp like that for our skills. So once we all figure out our schedules, I think within a few weeks I'll have mine. Then we can see what weekend or what days we can all come out.
Part of a boot camp, part of boot camp is nobody likes a boot camp. No, we want our boot camp to be likable, but part of our boot camp has to be understand how these images are produced. Because if you understand the basic how these images are, you can deduct so much of it, and you can get miles farther than anybody else if you know how this image come to be. Okay, so let's dedicate a small fraction of our boot camp to physics of radiology, how images are produced.
That would be nice, because just like learning the history of something, it'll help you never forget because you understand the deeper meaning.
Exactly. Then you can never, mistake it. People who don't know the images are produced mistake artifact for real and vice versa. People who understand, like, there is something as well in the skull. You ask about, do only the metal gives you streak artifact? No, in the skull you have lots of dense bone, and if you're not careful, you get a normal streak artifact of our edge of our bone for a subdural hematoma, and that can huge consequence for the patient, the treatment. Okay, but if you understand how those artifacts are produced, any dense thing in the skull can, for example, give you those artifacts. Then you look for sign of it, and then you don't mistake it for a real pathology. Okay. You guys have a good weekend.
Thank you so much.
We continue this in 2 weeks. Thank you. Bye-bye.
Sounds good.
Thank you.
Take care.
Bye-bye.